Welcome to this BTOG Podcast Series. My name is Newsom-Davis. I am the Vice Chair of the BTOG Steering Committee and a Medical Oncologist based in Chelsea and Westminster Hospital in London. This is a regular podcast, a series entitled BTOG Does, where we will be having informal chats with an expert and hopefully answering some of the important questions about subjects we face every day in the management of patients with lung cancer. It's important to say that sponsors of BTOG do not have any role in the choice of subject, the planning, the content, or delivering of anything that we are discussing. So today it's a great pleasure to introduce my colleague, Professor Samreen Ahmed. Samreen is a Professor of Medical Oncology at University Hospitals in Leicester, and we are going to be discussing EGFR mutated lung cancer. Samreen, welcome to the BTOG Does podcast.
Thank you, Tom. Thank you for BTOG for the invitation, and I hope I can add something informative to this today.
I certainly hope you can as well. So first of all, we're going to be thinking about how we pick up EGFR mutations. Now, I think most of our colleagues are going to be doing mutation testing for patients with non-squamous, non-small cell lung cancer routinely. I hope we are. How do we pick up EGFR mutations? There's been some change from PCR-based testing to NGS-based testing recently, so that's polymerase chain reaction versus next generation sequencing. What's your view in it, and what are you doing in Leicester, and what are the pros and cons of each approach?
So I'm glad you've mentioned that, because all of these mutations are really reliant on the detection of them to be able to treat them, and it's absolutely imperative that we get comprehensive analysis of what type of mutations they are, because this world is changing very, very quickly, as you and I know, and we have a whole host of drugs related to the paired mutations. So in Leicester, unfortunately, we're a little bit behind the curve. We're definitely not doing next generation sequencing yet. Our genomic hub isn't up and running in order to be able to process the number of lung cancer patients we have, and therefore we have an in-house polymerase chain reaction PCR panel that we use for both EGFR and BRAF mutations together. And the limitation of that is that you are only going to pick up the panel that you have the specific mutations that you can target. Whereas obviously next generation sequencing will pick up all mutations that are not expected to be there. So that is the main difference. And therefore in the PCR panel, you are likely to miss the rarer mutations. Now, I think the good thing about PCR panels is that the failure rate is much lower. You don't need that much DNA if you're only doing that panel. NGS failure rates are because of the quality of the DNA. So there are roundabouts, but as the technology of NGS improves, I'm hoping that we can all move to NGS so we get a full comprehensive panel of mutations, not only a specific panel, PCR panel, say for EGFR.
Absolutely, and I think it's fair to say that as part of the national genomics hubs coming into the UK, that NGS is going to be seen to be the standard, and I guess the rarer mutations are things like exon 20 insertions and other rare EGFRs like the G719 class of mutations. What's your take on these? I mean, the commonest ones we see are exon 19 deletions and L858R mutations. How are the exon 20s different in terms of patient demographics, and how are they different in terms of treatment? Because they are very different, aren't they?
Absolutely. I mean, I've been caught out before, when you are told that you're seeing a new patient. I was told that he had an EGFR mutation. I was all set to prescribe my EGFR TKI. But then when I got to the report, it said exon 20 insertion. We all need to realize that though it may be an activating mutation, it is resistant to our standard EGFR TKIs. So this is the key difference, that your patient's not going to respond to the drugs that we are used to now, such as osimertinib, afatinib, gefitinib. So the key thing here is that we recognize that this is a group which is different, though it occurs in the same area as the EGFR activating mutations. This is resistant to EGFR TKIs.
Yeah, and I think you made a really good point there, which is in all molecular analysis reports, there has to be an interpretation of that. So always read down to the bottom, always read the interpretation. And what I do when I see a mutation, I don't quite know what it means, is I phone up the molecular pathologist and say, what does this mean? Because it's really key. And I think that point about exon 20 insertion mutations not being sensitive to standard TKIs is key. And there are rarer mutations, like I mentioned one or two, so G719X mutations, S568I. You can actually use TKIs, but it's going to be a little bit different. And so you want to, again, have a chat to your pathologist.
So I would like to give a tip to those who don't have an expert like yourself at the end of a phone. So I use My Cancer Genome, and this is a website which is very well established, ratified by NCI. So it's really important that you go to a website that is trusted and you know the information is going to be correct. So My Cancer Genome is excellent. I don't remember all of those numbers in terms of the mutations, so I just put them in, click lung cancer, and up it comes with all the studies that have been done, all the data behind it, and it will tell you whether it's sensitive or resistant to the particular drug you want to use.
That's great advice. And of course, you can also learn about it through regular attendance of BTOG conferences and webinars, and you will therefore become an expert yourself. Okay, so we've done common, we've done uncommon mutations. Let's say you found a common mutation in someone who you're expecting this, it's been picked up on your PCR or your NGS, and it's an exon 19 deletion, your common mutation. What is the standard, most common first-line treatment for this kind of patient, Samreen?
Well, we had lots and lots of choice, didn't we, before? And we still have lots and lots of choice. But I have to say, we are fairly disengaging our brains now as we start, because the data is so strong towards osimertinib. So for me, practically speaking, unless there is some specific area that I'm really worried about, particularly perhaps a high risk of pneumonitis, osimertinib is my first go-to. So that, I suppose, blows everything else out of the water. For me, clinically, that's my choice. I think if there were some particular patient characteristics that you're worried about, you may go for others. But in terms of toxicity, efficacy data, I'm very convinced about osimertinib first line.
Yeah, I think you're absolutely right. And I think it's by far the commonest used. I think as we've used more of it, we've learned there are some side effects that perhaps weren't described so much at the beginning. For example, there can be effect on cardiac function. And it's worth reminding people that if you look at the SPC or the summary of the product characteristics, it does recommend baseline ECGs and doing an ECG every cycle for at least the first 2 or 3 cycles, and also doing a baseline echo and an echo about 3 months into treatment. I really would recommend people do that. It's now on a list of recognized cardiotoxic medicines, even though it's comparatively uncommon to see that. You mentioned exon 20 insertion patients do not tend to respond to drugs such as osimertinib. So would you be using chemo instead for this group of patients?
It depends what trial availability you have. We have TAC 788 study open, which is the first line.
Mobocertinib.
Mobocertinib, thank you very much, exactly. So mobocertinib randomizing versus standard of care chemotherapy. And if you have access to other trials, that would be your first go-to. It's certainly not commissioned as yet. So chemotherapy plus or minus immunotherapy would be your first choice. Immunotherapy in this group is not something that I would recommend, I have to say, because they're generally non-smokers and they really respond quite well to pemetrexed-based chemotherapy. So that would be my go-to.
Yeah. That's a really important point. We know conclusively that even if someone has a high PD-L1 expression, PD-L1 100%, if they have an EGFR mutation, first-line immunotherapy is not an effective treatment. Do not use it. That's been shown in studies. What about these rare mutations? The other ones we've talked about, the G719 group, the S568, or another mutation that might come out. Osimertinib, is that the one for those, or should we be reaching for our My Cancer Genome and see what they think?
I mean, I think you're probably more of an expert at this than I am. I haven't, because we don't do NGS here, I've not had that many rarer mutations to be able to target. I have to say I'm not that convinced with the data, but perhaps you could tell us about your practical experience.
Yeah, I think lack of data is absolutely what it is the problem. Afatinib has putatively more evidence behind the wider mutations, just reflecting the fact that in the studies, they often accepted uncommon mutations. And I think there is some evidence behind afatinib, and certainly I've used that recently, a patient with a rare G719X and an S568I co-mutation, and actually N equals 2, but both those patients responded to afatinib. I don't think there's a right or a wrong, actually. I think you can do either, but you could certainly look up the data. There's some quite good papers summarizing what the active data is. I just think if you do have a rare mutation, just make sure you've recognized what it is and you've had a little think about it before doing the reflex reach for the Aussie.
The only thing I was just going to add was that your main EGFR studies really only included your exon 19 and 21 exon 19 deletions and exon 21 mutations. So really, it really then leads us to think, well, the other mutations, we have very little data. So it's mainly phase 2 data.
Yeah. So let's think about brain disease. Imagine a patient who has come along, they've got the EGFR mutation, you were going to reach for your osimertinib, you do a baseline MRI, and my personal view would be in people with EGFR mutation, we should all be doing baseline cranial imaging because the risk of brain metastases is very significant. Let's say you find some brain metastases, they're actually asymptomatic. What's your view on what you do? Do you involve neuro-oncology MDTs? And what's by and large the approach of that process? Do people go for stereotactic radiotherapy surgery, or do we sometimes look at just pursuing our osimertinib and seeing what happens?
That's a great practical question. I think we're all scratching our heads as to know what to do. I am with you, Tom. I screen at baseline, and I've learned from previous mistakes and have my fingers burnt. So I'm now screening everybody at baseline. And I think we should be doing that. As you say, it's a high proportion of patients who will have brain metastases. But I would warn our audience really to make sure you counsel the patient that though they may be completely asymptomatic, if there is finding of brain metastases, it's imperative that they inform the DVLA. And even if they're asymptomatic, they will not be able to drive. Then we come onto the treatment. Osimertinib, as you know, is very good CNS penetration, and the new TKIs that we're seeing in phase 1, phase 2 studies are also very CNS penetrant. So hopefully we will get better and better control systemically, intracranially. However, whilst that is still in development, I think it is important that we discuss all our patients at, we have a super regional brain mets MDT. And even if I'm not going to refer them to stereotactic radiotherapy in the first instant, because they're asymptomatic, I do get them reviewed at the MDT so they have some follow-up data. And then I think the imperative is to follow them up. So at 3 months, don't forget to do your MRI when you're requesting your extracranial assessment as well. And at that point, if you feel that they are being controlled or they're actually reducing, and I've had a couple of patients who just with osimertinib have done very, very well, keep monitoring. The trouble is, once you lose brain tissue or get symptomatic disease, you probably don't get that back again. So this is where my nervousness starts, that if you've got a big lesion and you feel that that is unlikely to be controlled on systemic treatment, treat that. But there's no right or wrong answer. Generally, if they're asymptomatic, I tend to press on with systemic treatment and add in stereotactic treatment if they become symptomatic or we see radiological progression or instability.
Yeah, I think that's really helpful. And I guess the key absolutely is picking it up early, do your scans, involve a multidisciplinary team. And there isn't a one size fits all. You can go for either approach. And I agree with everything you say, as always. So second line treatments, people had their osimertinib. Let's presume they're on that. They're progressing. We've decided a switch of systemic therapy is required. You've got a couple of options. You've got pemetrexed, carboplatin. You've got Impower 150, which is carbo, Taxol, atezolizumab, and bevacizumab. And in the exon 20s, actually licensed, although not yet funded through NICE, we also have agents such as mobocertinib and amivantamab. If we're thinking about the Empower 150 versus chemo, do you feel strongly? Do you offer both, and it's the patient's choice? What's your views?
So I think availability is obviously key, because this is a massive area of research, and as presented in our BTOG last webinar, this was dominating the whole of the research arena. What do we do with these patients post-osimertinib? So you're obviously going to go to what's available. I have to say, if they're very fit and well, I go for the Empower 150, so 4 drugs together, chemo, atezo, and bevacizumab. However, if I feel that they're going to struggle with that, then I may just go for chemotherapy and immunotherapy alone. You could just go for chemotherapy alone if you feel that they might have toxicities with immunotherapy. The key area of development is going to be what we're looking at in the Chrysalis study, and I believe you're one of the PIs with that study. And that's really looking at genomic resistance appearance. So there are a number of mechanisms of resistance to osimertinib. A lot of them are something called MET amplification. You're not going to really pick this up unless you do next generation sequencing post-treatment on these patients, either with liquid or with tissue biopsies. So there's a number of mechanisms, and those drugs are specific to those mutations. So for MET amplification, and there is a study which has recently reported the Chrysalis study, and that's looking at amivantamab, as you say. That's an intravenous antibody looking at, and in combination with lazertinib. Lazertinib is a very penetrant EGFR TKI, and so the combination of that has shown very good responses. Amivantamab is intravenous, lazertinib's oral, so there is an issue about intravenous treatment, so we'll have to look at that. Combination looks at very good responses. We need to be mindful that they can cause pneumonitis, so be mindful about that. It looks as if lazertinib is very CNS penetrant. So that's one of the views to look at.
Brilliant. So in a last minute or two, adjuvant osimertinib now is licensed for patients with early stage lung cancer who have had surgery after chemo, if you're going to give chemo, or if you weren't going to give chemo anyway, and is actually funded at the moment. It's funded through the Project Orbis. Has only shown disease-free survival benefit because we haven't got enough mature data to show overall survival benefit. In 30 seconds, Samreen, what's your view on adjuvant osimertinib? Are you a believer based on the very impressive disease-free survival hazard ratio of 0.17 or thereabouts? Or are you I need to see the overall survival benefit before I stick my patients on, I think it was 3 years, of adjuvant osimertinib?
Yeah, great question. Nobody really knows. We should really, if you're a purist, wait for overall survival data. It's going to take ages because these are such good, effective drugs, and it's all event driven. So you're not going to get overall survival difference data for ages. So you've got to go on disease-free survival data. So you can't deny patients a very active drug on the basis that we're waiting for further data. I think if tomorrow I had a patient who was suitable, I would put them on chemotherapy, then followed by 3 years of osimertinib.
Yeah, actually, I must say, I have started a couple of patients, and it's interesting to see. And I guess we'll see the overall survival data when it comes out. I must say, I was quite convinced by the DFS benefit. It was pretty impressive. It's easy to think one thing when you see the conference presentation, but when you're in front of a patient with an EGFR mutation, it's quite a different thing. And I've used it on 1 or 2 people so far. So that takes us to the end of the podcast. Thank you very much for listening. Thank you particularly to Professor Samreen Ahmed for her insightful thoughts on EGFR mutated lung cancer, and we hope that was beneficial. For more information on BTOG events, including educational things coming up, and most importantly, how you can become a member, you can, of course, visit www.btog.org. But we thank you for your attention, and we look forward to you joining us at our next podcast.